So thanks again, Davide, for inviting me, and thanks to all of you for being here today. So I will probably, then Davide will let me know if I'm on time or not, talking to you about two studies. One is about the link between adverse life events and dementia and early onset dementia. So glad Davide mentioned that. And another one is about depression and the risk factors for depression in Parkinson's disease. So let's see if I will be able to say everything that I want to say. So that's the start. So the risk factors for dementia, the risk factor we can modify now. We know it's quite clear that depression and social isolation are two risk factors for the development of dementia. But this scheme, which is now 2020, so now need to be probably updated, doesn't include stress. I guess we are all familiar with stress. So I think we need to think about inclusion of stress in this list of risk factors. But why? So basically, these two studies actually are not so recent, 2010 and 2011, already mentioning the effects of stress and work-related stress in the second case, linking stress with dementia, vascular dementia in the second one, and in all cases, all causes dementia in the first one. But a more recent systematic review looked at stress both in every kind of dementia, linking to every neuropathology, so both vascular, AD, and other pathology. And they suggested that actually stress, especially if experienced early in the lifespan, as well as experienced chronic stress, are a risk factor for the development of dementia. And stress, with the word stress, we mean also PTSD, so all the related psychopathology to stress. I just would like to have a look with you at some of the comments that these authors made in their systematic review, because in my opinion, and hopefully also in yours, these comments, these reflections are quite interesting. First of all, of the risk factors mentioned before, many of them could be considered proxies for stress exposure or stress responses. And also, the association between depression and dementia could actually be an association between stress and dementia, with depression being a consequence of stress exposures and chronic stress. So stress is possibly the fundamental risk factor, with depression a manifestation of psychological stress. But not only stress could be the risk factor, with depression being the manifestation, but other manifestation could be actually linked to stress, smoking, and all the other lifestyle factors we were mentioning before, physical inactivity, unhealthy eating habits. So many of the other modifiable risk factors could be linked to the experience of stress, hypertension, and socioeconomic disadvantage, other factors that we should consider. So that's why I am personally interested in understanding the role of stress and the link between stress and dementia. From a neuropathological point of view, I won't have this kind of data to show you today, but I thought that this was important to say the possible biological mechanism linking stress to dementia is always a link involving the biomarkers mentioned before, the tau, the beta amyloid, as well as the inflammation and the cortisol. So just going through few of the graphs and the models that have been published recently. In this case, of course, we are talking mostly about AD neuropathology, but other models are also trying to be more comprehensive, always, however, talking about the main biomarkers that we mentioned before, so beta amyloid, tau, as well as cortisol and inflammation mechanism involved in the link between stress and dementia development. I like this also because it doesn't really talk about the biological mechanism, but it talks a little bit more about what we could mean, how we could measure how we could use to measure stress. So basically, both environmental stressors, major life events, and maltreatment. So in the study I will show you now, we focused on major life events as a possible stressor, as a possible source of stress during life. Also, we didn't focus only on the link between major life events and dementia onset, and dementia itself, but on dementia onset, on the early onset versus late onset. So we cannot really talk about the risk today, but we are trying to talk about the link between the age of onset and the presence of adverse life events. Because mainly, as Davide said, the majority of the studies are focused on the late onset dementia. Early onset is a different story. It's treated like a different pathology, but in this case, it's quite important to think about if stress could be an accelerator, could be a mechanism that anticipates the onset of dementia. Why focused on early onset? Because there is also an increase in prevalence of this kind of dementia. So it's quite important to understand the risk factors also of this manifestation. With early onset today, we will focus on the cutoff of 65 years old, even if I know that other literature could use a 60 years old cutoff, but today we're going to focus on the 65. We use a 65 years old cutoff. Our hypothesis is of a negative relation between the presence of adverse life events and the age of onset, such as higher is the frequency of adverse life events in your life, lower would be the age of onset, so earlier would be the onset of dementia. So to test this hypothesis, we ran a retrospective studies. I didn't say that, but actually this hypothesis and this study was inspired by the clinical practice where we saw that actually the early onset, the patients with early onset dementia actually had reports of more adverse life events. So we wanted really to put in numbers this observation, this data coming from this qualitative data coming from the observation. So we collected the records of 60 patients with young onset, and 50 patients with late onset dementia. And as you can see, the etiology was quite mixed, even if a majority of them were AD. With frontotemporal dementia, subcortical, vascular, and mixed. But as you can see, the majority of them were Alzheimer's disease. Of course, age was different between the two groups. Age of onset, of course, was different, but also levels of education was different, with higher education in the young onset dementia. Importantly, the baseline mini mental state score was not different between the two groups. And then I ask you to keep in mind this detail to take it back for the interpretation of these results. So these are the events we found in their records. In this slide, you can see a variety of adverse life events, but then we try to group them in more physical stressor and psychological one. Always, of course, considering that a physical stressor also has a psychological stress as well, but at least is a main physical, such as cancer, any surgery, any physical illness. And then all the other events mainly affecting the psychological side. So any familiar events such as illness of a family member, conflict within the family, early childhood events, adoption, abandonment, death of loved one, that was quite frequent. Any conflicts also with friendship and as well as divorce and separation, major stress, financial and work difficulty as well. We try to group these events based on the most frequent scales that assess this kind of variables. So, for example, the geriatric adverse life event scale and other methods. Then we compared the young onset dementia group and the late onset dementia group. We did a correlation considering the entire group as well as a regression analysis, tried to understand the predictors of the age of onset. Okay, so we cannot again talk about the risk of developing dementia, but just the age of onset as the dependent variable. First of all, in the late onset group, there was a more frequent report of physical adverse life events, while the contrary was for what concerned the early onset, with more frequent report of psychological events. Same results we obtained and trying to analyze the different, so not just the two groups, but the different events that I showed you before, with more frequent report of illness of a family member, divorce, separation, and loss of employment for the young onset group, and higher frequency of reports in the late onset group for surgical intervention and death of a loved one. In the correlation, if we correlate the total amount of events and the age of onset, the correlation didn't reach significant level. There was a negative value as well, so going in the right direction according to our hypothesis. But this significant negative correlation emerged between the dementia onset and the frequency of the report of illness of family member and the divorce separation. Again, for what concern the late onset, so in this case, we have a positive correlation. Higher is the age of onset and higher is the frequency of the death of a loved one as an event. Regression showed the same results, considering as predictors both the psychological and the physical events as a categorical variable, so just absence or presence of this kind of events in the records. We found the same results. So psychological events were negatively correlated, predicted the age of onset, while a positive association emerged between the physical events, the physical stressors, and the age of onset. So more physical stressor for the late onset, more psychological stressor for the young onset dementia. So we have many limitations, of course. The first is that these kind of events were recorded in the records, but without only with the clinical interview, without a formal instrument. So that's a main limitation that actually inspired us now in the construction of a new instrument that could be used in the assessment to assess the adverse life events in the entire lifespan rather than in the last year like other instruments are doing now. But despite the limitation, I think that this couple of results suggest that stress could act not only as risk factor, again, we cannot talk about risk factor today, but could be also a modulator of the dementia age of onset that could be associated with the early onset dementia, especially if we talk about the psychological stress and not the physical one. Of course, these results hopefully will open new research questions. So what about the physical stress? Why is positively associated with the age of onset? Why more physical stress is associated with late onset? Is actually age of onset another way to say age is just because they are older and not because they develop dementia later. Is there a role of the care we receive for physical stressor for any kind of illness that is not actually granted for what concerns psychological stress, the kind of help we receive and care? Or is there a biological difference, as this very interesting study suggests, between the effects of physical versus psychological stress, with the psychological one having stronger effects in the long term? So this, I don't have the answer for this question, but I wanted to share them with you because I thought that this was something that we should think about. So including stress between the risk factor, trying to address these adverse life events in the lifetime in a systematic way when we assess the cognitive profile of patients with suspect dementia, and trying to understand also the biological mechanism linking psychological and physical stress. These results are in line with a recent model actually suggesting that less, and I said psychological in this case, stress could delay dementia onset. So good news, at least, and if we manage stress, if we try to reduce the stress in our life, maybe, we cannot really prevent, but maybe we can delay at least the development of this kind of pathology. And again, really thinking about seriously including stress in the list of risk factors to then allow also the development of management strategies to reduce the risk. Okay, I'm jumping in the other. I said if I want to be on time, that's my thank you slide, but I will keep it for later. So I think I'm in time to then now talk about depression and anxiety, which was not in the title, but I couldn't mention anxiety as well because of the high comorbidity. We change a little bit scenario now because we moved in a pathology that sometimes is a bit, not considered in the dementia field, which is Parkinson's disease. Why is not considered? Because not that the about 50% of the patients with Parkinson's disease develop dementia, so it's not like Alzheimer's. However, it's the second most common neurodegenerative disorder after Alzheimer's disease. Also, dementia happens. And I was talking before, and I said Parkinson's disease could be a very good model to understand why somebody developed dementia and somebody else do not. So I think it's quite important to understand Parkinson's disease and the non-motor symptoms of Parkinson's disease. So that's what I'm doing what I did in the last 10 years. Understanding Parkinson's disease, understand cognitive decline, now more recently understanding the relationship between the affective symptoms of Parkinson's disease that, as you can see, can appear quite early in the disease, sometimes even before the motor symptoms. So depression, anxiety can be prodromal symptoms of Parkinson's disease. And how can they modulate cognition and cognitive decline in Parkinson's disease? In this study, however, I would go a little bit in a different direction because, of course, the link between depression and dementia is quite clear and it's quite established even in Parkinson's disease. But because of the fact that these symptoms are core symptoms of Parkinson's disease, I think it's quite important to understand the predictors of those symptoms, because if we act on them, then maybe we could act on the cascade event linked with these two manifestations. So just a couple of numbers. Why depression and anxiety? Because they are quite prevalent, at around 40% for what concern depression and 30% for what concern anxiety. And they are not only predictors of cognitive decline, but they are also predictors of other very important manifestation of Parkinson's disease, such as impulsive compulsive behaviors. So it's quite important to understand what are the predictor of these two negative affect manifestations in Parkinson. We don't have many information about predictors of depression. We have this recent study investigating the differences between depressed and not depressed patients with Parkinson's disease, showing that patients with Parkinson and depression were younger when the disease happened, but the age of onset was lower educational level, longer disease duration, so more severe even pathology. Higher UPDRS score means more severe motor symptoms. Same for the Hohenn-Yahr stage, higher stage means more severe motor symptoms in Parkinson's disease, as well as lower cognitive profile and lower level of ability and autonomy in the daily life. Depression was also associated with sex, genetic risk factors, but also apathy, anxiety, and fatigue. Again, the comorbidity between depression and anxiety is present here as well. For what concerns anxiety, we have a couple of studies that suggested that, again, in this case, older age is associated with anxiety. REM sleep behavior disorder are associated too. But again, worse cognition at baseline is associated here with anxiety, and the previous slides we show with the depression as well. Motor symptom severity seems to have a role in anxiety as well as autonomic dysfunction. So in this case, see the animation, you shouldn't use animations. That's a summary about the predictors, or at least the factors associated with depression and anxiety in Parkinson's disease. What about education was our question, because I guess we all know that education could be considered as a proxy of cognitive reserve. I'm not going to explain what cognitive reserve is. I guess we all know that. But I'm not sure we are aware of the fact that in the recent years, cognitive reserve is starting to be associated also with affective manifestation of neurodegenerative disorders. So not only cognitive decline, but also development of this kind of symptoms. So our question was, our aim was to expand the understanding of depression and anxiety predictors in PD, addressing some of the limitation of the previous literature, considering a longer time window, so 5 years longitudinal approach, a larger sample size, considering not only Parkinson's disease, but also healthy controls, and testing, again, the role of education, not only for what concern anxiety, but also for what concern depression in Parkinson. We use the PPMI database, the Parkinson Progressive Marker Initiative, 423 patients and around 200 healthy controls. And we extracted these measures from the database. So as a proxy of cognitive reserve, the level of education, and as you can see, the list of tests for both affective components, cognitive status, and both motor symptoms and sleep disorders, because they were all mentioned in the literature. So that's the baseline. Depressive symptoms in both PD patients and healthy controls. I'm going to show you the graph. I think it's quite, it's more useful, but in this data, you can see that actually patients with Parkinson's disease, when compared with the healthy control, showed both a lower cognitive profile, a lower score at the MoCA, but also higher symptoms of depression. And that's what happened in the 5 years time window that we saw. Depressive symptoms stay stable for what concerned the group of healthy controls, while it go higher in the PD patients group. So we tested the model of that I mentioned before, regression model, considering the cognitive status, the education year as a proxy of cognitive reserve, the disease duration, the age of onset, the gender. We included gender because it was not actually considered in all of the studies. The UPDRS-3 score, motor symptom severity, the time, of course, because there was an increase of the symptomatology. We consider apathy, again, because of the comorbidity, fatigue, and we tested also the interaction between education, cognitive reserve, and cognitive status. And what we saw is actually when we put together all these predictors, the one that still keep to be significant are education with a negative relationship, cognitive functions, again, negative, motor symptom severity, higher motor symptom severity, higher the depressive symptoms. Again, similar positive relationship with apathy, comorbidity, and with fatigue. But the interaction is quite interesting, in my opinion, because again, we see the association between cognitive performance. I wouldn't talk about decline, and you can see this kind of database contains that many data, but of patients with a very high level of education and quite high score at the MoCA. So I wouldn't talk about decline, but I would talk about more generally cognitive performance, with a negative relationship between depressive symptoms and cognitive performance more stronger in patients with low level of education. So we could assume low level of cognitive reserve. Same results we obtain for what concern anxiety, even if, as you can see, the anxiety profile, the anxiety symptoms profile in both controls and PD patients was stable in the 5-year window. So that's a difference between anxiety and depression. But similar results with, I'm just going to don't know how to push, but I guess it's here. Yes. So again, an interaction between year of education and a test that measured the autonomic dysfunction in Parkinson's disease, with again stronger relationship between depressive symptoms and autonomic dysfunction in the patients who had lower level of education, so lower, we could assume, cognitive reserve. So these results are actually in line with one of the study we conducted this year, investigating the role of cognitive reserve as not a direct predictor, but as a moderator of the relationship between other two symptoms of Parkinson's disease. In this case, we consider executive dysfunction and REM sleep behavior disorder. And I think opens new questions again about the role of cognitive reserve. And in this case, I should talk about more levels of education, just to be more precise. It could open, I think, more questions about the role of level of education also in the development of other symptoms of these neurodegenerative disorders. And importantly, this relationship was present both in Parkinson's disease, but also in the healthy control, with a significant relationship between years of education and depressive symptoms and anxiety symptoms in healthy control, despite they didn't have the same level of symptomatology of PD patients. So for sure, we can say that at least both PD patients and healthy controls, if they have a low level of education, they could be more vulnerable group, not only to cognitive decline, but also to the development of this other negative affect manifestation, which could be a prodromal manifestation of a neurodegeneration or a risk factor for the development of cognitive decline. But if we confirm this relationship, again, I like to end my presentation with question myself. You know, you never know if audience will do questions, so I do a question myself. So what could be the biological and psychological mechanism underlying the link between educational level, depression, and anxiety? It's about metacognition. It's about health literacy, why people with low level of education actually experience more symptoms of depression and anxiety. It's about health literacy, again, the level of, asking for help, the level of care. Do patients with high versus low education and maybe cognitive reserve respond differently to treatment for anxiety and depression, to psychotherapy, to pharmacological intervention? Do we know that? Should we take into account the level of education when we consider this kind of other manifestation? And last, should we maybe consider correcting for education also the questionnaires that we use to assess anxiety and depression, as we do for the other tests that assess cognition? We always correct for education and age when it comes of, cognitive assessment. We never thought about correcting for education a scale that is assessing depression, for example. But if actually this link is going to be confirmed, maybe we should think about this. We should think about how two different persons with same symptom could respond differently to a questionnaire if they are different in terms of level of education.